Hello and a very good evening to all. I, Dr. Dhamdeep Dabade, on behalf of Emcure Pharmaceuticals Limited, welcome you all on the occasion of Hypertension Therapeutics Conclave 2021, Module 4, based on the topic Treatment of Hypertension, which goal for which patient. Hypertension Therapeutics Conclave is the unique scientific initiative by the Emcure since last 1 decade, and this is the 11th year of this particular scientific event. This scientific event being led by our course director at every session, Professor Gurpreet Wandasar. It's my privilege and honor to introduce Professor Dr. Gurpreet Wandasar. Sir is the professor of cardiology at Dayanand Medical College and Hospital, Ludhiana, Punjab. He has been published with over 210 papers, most of them being published in the foreign journals of the repute, like the Lancet and etc. Sir is the director of Physicians Research Foundation of Association of Physicians of India for the year 2022 to 25. Sir, been the president of the Association of Physicians of India, been the president of the Hypertension Society of India, been awarded with Dr. B.C. Roy National Award for the year 2006, and been the editor of the cardiology section of the API textbook of medicine. With this brief introduction, now I would like to hand it over Professor G.S. Wandasar for the further proceeding of this event. Over to Wandasar. Thank you.
Thank you, Dr. Dhamdeep and Dr. Sanket. It's indeed a great pleasure. And from my side today, it's a very, very auspicious day because we have the Gurpurab and Guru Nanak Dev Ji, the first Guru of the Sikhs, his birth anniversary. 502 years back, Guru Nanak Dev Ji appeared in this world, and just a while back Dr. MP Singh was actually talking to Sanket and telling the simple advice, simple way of life which Guru Nanak Dev Ji taught us all. Naam Japo, which means we have to remember God all the time. Kirt Karo, you have to earn your livelihood on your own and not upon someone else, and you have to work hard for that. And Guru Nanak Dev Ji lived actually, he was a saint who was a worldly saint and who lived in this world. And Vand Chako means you have to share your income, your earnings, your education with others. And that is exactly what Dr. Matthew Wire is going to do today, actually commensurate with the teachings of Guru Nanak Dev Ji, that he's going to actually enlighten us on the treatment of hypertension. And he's going to speak today. Actually, this is the 4th webinar in the series that we have been having. And the previous lectures have been very, very educative. I have learned so much from his previous talks. Dr. Matthew Wire is actually going to speak more on the individualized kind of treatment, what goal for what kind of patients. He's a nephrologist of eminence from Maryland School of Medicine, Baltimore. And his primary interest is in high blood pressure treatment. He's actually contributed 600 manuscripts. He's authored 8 books. And he's on the review board of almost 30 medical journals on hypertension and nephrology. He's on the editorial board of over 18 journals. So he's a very, very distinguished personality. And he's done a lot of original works, landmark trials in hypertension he has conducted. And it is really actually, it's a pleasure to listen to him because he's also a very articulate teacher. We have 3 very distinguished panelists. Dr. Uday Jadhav is professor and a faculty in cardiology from the Department of MGM, Bombay, a very close friend. And he's been a member of the Medical Council of India. In fact, hypertension is very close to him, although he practices all aspects of cardiology, but he spends a lot of time on managing hypertensive patients. He's written books on hypertension. He's been a principal investigator of RAS India study, which he presented at the AHA joint meeting. And he's authored some chapters for the ESH, and he's also worked on, of course, cardiac CT. He's presently the Vice President of Heart Failure Association of India. Besides him, we have actually Dr. Narinder Pal Singh, a personal friend of mine, who has been with the Maulana Azad Medical College earlier, then worked with the Max at present with the Max Healthcare. He's a faculty member of our Indian College of Physicians for many, many years, has been a president of the Hypertension Society of India. He's been president of Delhi Nephrology Society and vice president of the Delhi Medical Council, a very diverse personality. And it's always a pleasure to listen to Dr. N.P. Singh. So he and Dr. Matthew Wire are the two nephrologists that we have. Besides Dr. Uday Jadhav and Dr. Narinder Pal Singh, we have a very pleasant diabetologist from Jaipur, Dr. S.K. Sharma. He works in Galaxy Specialty Center, Jaipur, and has multiple publications. You will just see, actually, he's such an authority on diabetes and hypertension that he always adds very significant amount of information to the panel discussion. So I look forward to the discussion with these three experts from India after Dr. Matthew Wire's talk. And over to Dr. Matthew Wire, please.
Well, good morning, good evening, depending on where you are. It's a great pleasure to be here. Hopefully you can all see my slides now, which are on the screen. Are they all visible?
Yes.
Just want to make sure. So again, it's a great privilege to participate in this educational program. These series of presentations on high blood pressure and its management, I think, are just so instrumental in our process of improving clinical care. And especially so in a pragmatic way, depending on where you live, how you practice, with many different types of clinicians and specialists. So it really, I salute the Emcure team and the panel of experts who are working on this program to provide such an amazing opportunity to discuss so many important issues in clinical care. Today, we have a really challenging topic, and that is the goal. And let's agree that everybody's different and no two people are alike. And I think we have to be careful about how we generalize our blood pressure targets for each and every patient. We will look at what the guidelines say in generality, but we must remember individualization is so very, very important. Here are my disclosures, none of which really have any bearing on our topic today. So these are the three key single overriding communication objectives that we'll have for today. And that is to appreciate the continuous relationship between blood pressure and cardiovascular and renal events. To understand that how and when we measure blood pressure may play an important role in determining the benefits of treatment on the heart and the kidneys. And what I mean by that is, again, office readings versus home readings at rest versus exercise. I mean, there are many different facets because in a sense, we treat a dynamic range of blood pressures in all of our patients and even ourselves. And then, as the point I made earlier, careful individualization of blood pressure goals are very critical and important in each patient. So we'll look at some of the historical perspective here. We'll touch on the SPRINT study and how that's really had a major influence on subsequent guidelines. And I'll focus some of the commentary on some of the US guidelines, realizing, of course, that many countries have different perspectives. I mean, there are Canadian guidelines, European guidelines. I know you have Indian guidelines. And this is all appropriate given the fact that we treat somewhat different population groups with different degrees of cardiovascular risk. So let's start back to the 2014 hypertension guidelines. These, as you will recall, were very much based not on expert opinion, but on absolute raw data. So back in 2012 and 13, when the committee met to review all the available data, of course, they did not have the SPRINT study. And you can see how this obviously resulted in what I think we would say is a very liberal approach to treating blood pressure. That is 140/90 or 150/90, depending on your age. So let's agree, obviously, the SPRINT study has changed all of that. And you can see how the older guidelines here have evolved from basically 140 to 150/90 to addressing how SPRINT has changed all that. And of course, in the meantime, this classic paper by Sarah Lewington of 1 million people raised obviously important questions about how there is this incredibly linear relationship between usual systolic and diastolic blood pressure and ischemic heart disease mortality. And you can appreciate it. It's pretty impressive regardless of age. But this is observational information. It is not interventional information. So needless to say, there is a lot of confounding in these observations, but nonetheless, something to take stock in. And this obviously leads up to our conversation about the SPRINT data. I was actually on the Data Safety and Monitoring Board for this study. It was an amazing exercise in restraint. And the reason I say that is the people that were enrolled were nearly 10,000, average age 68, appreciate that the population groups are not typical for India, but nonetheless provides perspective on a U.S. population with its diversity of people of African heritage, Hispanic heritage, again, not Indian, but nonetheless a broad array of different population groups. And notice again, remember, the blood pressure was not too bad. People came in with a blood pressure of just under 140. The old 2014 guidelines, that means they're all at go. And as you can see, and I'm going to emphasize this here, there was a big blood pressure differential, but the way the blood pressure was treated was with automated, unattended blood pressures in the investigator office, okay? Automated, unattended. We'll come back to that later. But here's where we needed to provide restraint. Within a year of starting the study, we started to see the lines separate. At year 2, it was ridiculously separated. And the major commentary in our committee was, can we allow this to continue, seeing the divergence? And, you know, to be honest with you, half the group said no. And the other said that if we stopped it too early, no one would believe the data. And the study like this would never be repeated again. So we continued. And finally, as you can see, it was stopped with a mean follow-up of over 3 years. That's not a long time, let's agree, in our lifespan, but nonetheless, an impressive advantage for the lower blood pressure goal, which, as you can see, was consistently evident with a shift to the left, regardless of age, gender, ethnicity, et cetera, et cetera, et cetera. Everybody benefited. Now, I want to remind you all that a lot of people pay attention to the kidney, and the kidneys are near and dear to my heart because I am a kidney doctor, but I also know my people don't die from kidney disease, they die from heart disease. And although in this 3-year study, which did not have a lot of people with any risk for developing kidney disease. There was really no evidence that a lower blood pressure goal impacted the kidneys. But what we can say is whether or not you had kidney disease or not, you lived longer because you didn't have a heart attack or a stroke. And I think that's really the key issue. The fact that there was not a renal benefit did not surprise me, nor did it restrain me from considering lower blood pressure goals in my patients. And so obviously the impressive data has continued to appear in the literature. And this is a paper that just appeared a few months ago from China. They basically repeated the SPRINT study and, not a shocker, basically demonstrated the same results. So at least we have data now from China, from US in a diverse population, showing the advantages of lower blood pressure control in older people with high blood pressure. And as you can see too, this study was about the same size as the SPRINT study. You can see the blood pressure targets a little bit different, but nonetheless, a big study, randomized controlled, as you can see. And as you can see here, quite representative of the population there. No, very little kidney disease, but about 20% of the people had diabetes at the bottom. And please appreciate those with clinical cardiovascular disease at the very bottom. There are very few. So what this is basically showing us is that lower blood pressure is indeed helpful, even in people without a lot of risk for cardiovascular disease. Impressive. And again, notice how early the lines separate. So I think it's very nice that the Chinese did this study because they clearly have showed us that in general, older people with high blood pressure, a blood pressure goal that is lower than what we've traditionally done, results in fewer cardiovascular events than our traditional standard treatment goals. It is therefore not surprising that many of the global guidelines on managing blood pressure have changed. I share with you the American Heart Association, American College of Cardiology guidelines, chaired by Paul Welton. And you can see that the definitions of normal, elevated, and then stage 1 and 2 are shown here. You'll notice now stage 1 is at 130, not at 140. And for those of us in middle youth, even 120s is considered elevated. I think we have to be careful about that. And I'll come back to that a little bit later. So appreciate what Dr. Welton and colleagues stated in the guidelines. And this is verbatim, although a continuous association exists between higher blood pressure and increased cardiovascular risk, it is useful to categorize BP from public health standpoints. And you can see that. And the rationale for this is based on the observational data related to the association between various measures of blood pressure and cardiovascular risk. And of course, lifestyle modification will still remain important as part of any treatment strategy. And you can see there are pragmatic interpretations here. And let's agree that meta-analyses of observational data like that large Lewington study I showed you do show this relationship. So it is a perspective that we all need to consider as we treat our patients and choose our goals. So let's now move more towards how we measure blood pressure. And I'd like you to focus on the far left, first of all, for clinic measured blood pressures here in millimeters of mercury. You will see that depending on how you measure blood pressure, or I should say where you measure blood pressure, it is important. And you can see the various definitions. I would like to emphasize that unattended automated blood pressures done in the office most approximate 24-hour blood pressure measures at least the daytime part of that, okay? That's important because what's fascinating is if you look at clinic blood pressures, they're on average about 10 millimeters higher than automated measures that are unattended in the office. And so obviously how we measure blood pressure and how we interpret the blood pressures is an important part of our consideration. But I think the ambulatory blood pressure monitoring can be used to supplement the office and home readings. And I would encourage you to use the home readings because the home readings are also going to help you pick up people who have masked hypertension. That is hypertension that occurs out of the office, perhaps at work or under stress, that you don't pick up with office-based readings. Masked hypertension is as risky as fixed hypertension. But the beauty of automated unattended blood pressures are that it is very reflective of daytime ambulatory blood pressure monitoring readings. So obviously, this is why we as clinicians have to be careful about how we interpret home readings versus office readings and appreciate that there are different definitions and diagnostic methods for identifying people who may have the so-called white coat, where you're higher in the office and lower at home, or masked, where you're higher at home and lower in the office. I think really the game changer is the automated oscillometric blood pressure measurement. Obviously, not everybody can have this, but it certainly does provide a much more exact way of determining blood pressure, which mirrors 24-hour ambulatory daytime blood pressure measurements. And that's why I think this is a very exciting opportunity. And as you can see, people don't need to rest before you do it. And it can be done just once during an office visit because it provides so much specific benefit. And I'll share with you some data from very lovely meta-analysis published, a couple of years ago. What you can see here is the mean difference in systolic blood pressure between automated unattended in the office, that's the reference, and research blood pressure measurements. These are by people who are paid to be blood pressure experts in their measurement. All right. This is not your assistant or whoever happens to be around that day. It's about 7 millimeters of mercury, right? Difference. And as you can see, the research blood pressures are typically quite a bit higher. And if you just look at traditional office measurements, they can be up to 14 millimeters higher than automated unattended blood pressure measurements. So this is why we have to be very careful as we read the literature as to how blood pressure was measured in these clinical trials. And, if you look at automated unattended blood pressures and compare them to daytime or awake ambulatory blood pressure monitoring, they're almost identical. Take a look at that. Look at all these studies. Isn't that impressive? So basically, you may not even need ABPM anymore if you have an opportunity to use an unattended blood pressure measurement that's automated in your office. So pretty exciting stuff. So I think the automated readings are a major step in assisting us in properly determining a patient's blood pressure. And again, providing perspective that is most akin to daytime ambulatory blood pressure measurements. So what did the guidelines say about the treatment threshold and use of cardiovascular risk estimation to guide treatment considerations? And again, we're looking at the thresholds here, and you can see the level of evidence is high, more for the systolic than it is for the diastolic, and that's very typical for people who are over the age of 50 years. And as you can see, obviously lifestyle modifications always remain important, but using medication to facilitate blood pressure reduction in people with a risk of 10% or higher and an average SPP over 130 and 80 diastolic does make sense. And you can see exactly verbatim coming out of the guidelines here. And the recommendations for a blood pressure goal, largely based on the SPRINT data I shared with you, is a blood pressure target of less than 130 over 80 as determined in your office, and preferably with a good office measurement. What about diabetes? Well, let's first start with the fact that the SPRINT study excluded people with diabetes. It does not mean that they succeeded, though, because about 16% of the population had clear glucose intolerance or pre-diabetes, or however you would want to define that. And clearly they benefited as much as the people who did not. I cannot think of a possible rational explanation or biological explanation as to why people with diabetes, who clearly have more cardiovascular risk, would not benefit as much as people without diabetes with regard to a lower blood pressure goal. What's fascinating, though, is we really only have one study in people with diabetes. That was the part of the Accord study, but it was half the size of the SPRINT study. And, I think quite clearly there are multiple reviews, meta-analyses from clinical trials which support a lower blood pressure goal in these patients. But let's talk a little bit about Accord. Accord was not simply a blood pressure study. It had blood pressure, it had lipid lowering, and it had glucose lowering. And one of the concerns about more intensive glucose lowering was, of course, the concerns about sympathetic stimulation and its impact on cardiovascular events. And remember, Accord really basically showed nothing helps. Not blood pressure, not glucose or lipids, which tells you a little bit something about the study itself was not really well enough designed to answer the question, either in size or duration. But it did show a definite signal for less stroke. And if you look at the standard glycemia group, which is really what most of us do in clinical practice, and that's the second bullet point, and look at that with the SPRINT data, it is clearly evident that a lower blood pressure goal provided benefits. And that should not come as a great surprise. And so I want to share with you this next two graphics, which are very colorful. So if we're going to be considering cardiovascular risk of 10% or greater as our yardstick for choosing a lower blood pressure goal, please appreciate this data in men and women, smokers and non-smokers with blood pressure, and then the cholesterol to HDL ratio shown there. And obviously green and darker is your risk line, so to speak, for a more aggressive blood pressure control. And appreciate in the center the influence of age. But let me now change this figure and make people diabetic. And look how it changes. What this clearly means is that almost everybody with diabetes hits that 10% risk. And so, quite honestly, appreciate if you go back and forth how it also, diabetes neutralizes the gender advantage that women have over men. But again, it certainly suggests that the very vast majority of our patients will benefit from lower blood pressure goals. And let's appreciate in the Indian subcontinent, where there is so much genetic background for glucose intolerance and diabetes, quite clearly, many, if not most patients, will need a lower blood pressure goal. So out of the guidelines came these thoughts about diabetes with specific regard to treatment goals in the top box, but then treatment considerations including the frontline diuretics, renin-angiotensin system blockers, and calcium channel blockers. And I think we can all agree, certainly these drugs are the main therapies, and the vast majority of our patients are going to need all three. But certainly the bedrock will be a drug that blocks the renin-angiotensin system, especially in the presence of albuminuria. But let us also agree, proper non-pharmacologic interventions do make sense. And we should not forget that while we use medications to care for our patients. And the pharmacological interventions should be based on our blood pressure measurements and should be reconfirmed, and appreciate, as I note in the second bullet point, and we discussed this at our last session, the vast majority of people are going to need 2 or more drugs. So take advantage of many of the fixed dose combinations that are available to facilitate that. And actually, one of the most exciting therapies is, the single pill with 3 drugs, which I think really helps improve the overall compliance. And appreciate, as we've discussed previously in these lectures, that renin-angiotensin modifying drugs, thiazide diuretics, and calcium channel blockers really do make good sense. They all work well with each other and can even be formulated into a single pill. And these are the drugs that really are what we might describe as disease-modifying therapies. And if the patient does have micro or macroalbuminuria, it is always preferable to use the fully approved dose of that ACE or ARB in their treatment strategy. Again, this is the data that we have utilized from the diabetic nephropathy studies showing that they provide the necessary renal and cardiac protection. So please take advantage of those. And remember to monitor creatinine and potassium levels. But appreciate, if we have problems with potassium, it's best to mitigate the potassium problem without altering the dose of the ACE or the ARB or stopping it. Now, resistant hypertension is another category. I am not going to go into great detail on that right now because we're going to have another topic on that next time on this very issue. But one of the highlights of what we have learned is that the use of a mineralocorticoid receptor antagonist can be very, very helpful in many of these patients. So to put this into perspective, SPRINT has clearly demonstrated benefits with lower blood pressure goals, and the results of ACCORD and SPRINT are in fact generally consistent. And a SPRINT sub-study demonstrated that people with prediabetes derived a similar benefit as those with normoglycemia. And I've touched on this. So we should consider lower blood pressure goals in people whether they have diabetes or not. But I would like to emphasize that no 2 people are alike. Is there a right blood pressure goal for everybody or associated with what you see here? I would submit to you that lower blood pressure goals, if they are well tolerated, are optimal for both the heart, the brain, and the kidney. And this is going to be the case moving forward until we have any evidence to the contrary. So I'd like to thank you all very much for your attention. I hope I have stimulated a lot of conversation here. I know that many of you may not entirely agree with what I said, but that's why it's a great conversation point for us to move forward and have this conversation. So thank you again for listening to me today, and I look forward to the conversations we're going to have next.
Thank you, Dr. Matthew Wire, for this lovely discussion and for initiating actually the deliberations with these 3 experts. For the sake of reminding the audience, He did emphasize that individualization of therapy is very important. And Dr. Matthew Wire has emphasized that how and when we measure blood pressure, because there is a dynamic range of blood pressure that we are measuring. And it's very important to see where we are measuring blood pressure. He did emphasize quite appropriately the AOBP, the automatic office blood pressure, which is unattended. And he did tell us from very useful data that about 10 to 15 millimeters, the levels are higher on whether the research experts are measuring blood pressure or your paramedics are measuring blood pressure. In fact, paramedics might be a little bit better because they generate less anxiety. But he did emphasize that what we are looking at is actually what we are wanting to know is what is the blood pressure during most awake hours. And that is better represented by the AOBP, and which corroborates with the awake ambulatory blood pressure. It's nice that he shared with us the SPRINT study came 6 years back. And this year, actually, we had the Chinese study, and Dr. Wire has emphasized that they did include some diabetics. They showed similar results, almost similar targets. And so the SPRINT data gets emphasized further. Although he's an expert and he was on the data monitoring board, and it was nice to get it from him that there were thoughts of even this particular study was terminated actually at 3.6 years. But as he said, possibly there were some thoughts even before that too, because the Kaplan-Meier curves were separating so rapidly actually with the more effective control of blood pressure. The diabetic issue, some people had doubts because of the accord, but he has resolved, and we have an expert in Dr. S.K. Sharma, and we will like to hear from him because India has a large pool of diabetic patients. And so it will be nice to hear how Dr. Sharma actually feels. And as I am a cardiologist, obviously my first question will be to Dr. Uday Jadhav. And I would like to know from you, Dr. Jadhav, that what is the cardiac population actually? How will you interpret this SPRINT data and the whole lot of meta-analysis and other trials that we have today in patients with heart failure, with preserved ejection fraction, and heart failure with reduced ejection fraction? What targets should physicians be looking at in terms of blood pressure? Of course, they'll manage heart failure, but how would the blood pressure actually alter their thoughts regarding use of agents which have overlapping effect on blood pressure and heart failure? Dr. Uday Jadhav, please.
Thank you, sir. Thank you, Professor Dr. Gurpreet Wander. So, couple of quick comments thereon is that there is a little challenge in terms of what should be the blood pressure goals in patients with heart failure. Unlike all the categories of hypertension with comorbidities, here is a situation where excess lowering of blood pressure also could be truly a problem. However, given the fact that some of the class of medications, for example, let's say the RAS inhibitors, to be very specific, the ACE inhibitors, have been proven over a period of time to benefit hypertension and heart failure with the reduced ejection fraction, HFrEF. We did not have the same data with ARB, still the class of sacubitril valsartan, ARNI came on. And then we had this benefit of looking at heart failure event reduction and probably some benefits in the therapy of hypertension, though ARNIs have not been really approved as a blood pressure lowering medication all by themselves. The second class of drugs would be beta blockers that would help necessarily patients who have hypertension and heart failure with a reduced ejection fraction. MRAs, the aldosterone inhibitors, would again will benefit patients of hypertension with heart failure and reduce EF. So we have class of drugs that will serve the purpose. When we talk a little on the HFpEF aspect of hypertension and heart failure, there hasn't been really a great data to support any of the prior classes of medications that we use in HFrEF, whether it's beta blocker, ACE inhibitor, ARBs, MRAs, and for that purpose, even sacubitril valsartan. It's only till the SGLT2 inhibitors came in vogue and the data on empagliflozin got released at the ESC and recently at the AHA, where they talked specifically of a subgroup analysis of HFpEF, the LVEF more than 50%, stretching right up to 70%. And there the benefits have been seen. So apparently, when it comes to SGLT2 inhibitors, there seems to be, a continuum of benefits. But that would not be very true for any other class of drugs. This we talk about when there are two existent comorbidities, hypertension and heart failure. But prima facie, I think the most important understanding we would have is if one can achieve a good blood pressure lowering at a very young age of detection of hypertension in the lifetime of a person, the legacy effect over a period of time is going to prevent HFpEF for sure over a period of time, the further drop in the LVEF. So better the blood pressure control, more intensive the blood pressure control, we will certainly end up having a lesser incidence of heart failure. So those are my specific comments related to this aspect. Thank you, sir.
Thank you, sir, for clarifying how aggressively we should be pursuing in patients with heart failure, preserved ejection fraction. And my next actually thoughts are with Dr. NP Singh, because Dr. Matthew Wire did emphasize that in albuminuria we use these RAS blockers are very effective, and generally people actually count it as an absolute indication for choosing these agents as first line. He did mention mitigate the potassium levels and do not actually at a certain level when borderline hypokalemia occurs, do not withdraw RAS blockers because possibly the renoprotective, cardioprotective effects of these. So I would really like to know your thoughts for the benefit of the physicians attending this webinar and for myself as to what is, as a nephrologist, your approach. Till when do you continue using RAS blockers in patients with CKD, and even in fact maybe a comment on the MRAs also, mineralocorticoid receptor antagonists. So just enlighten us on your thoughts as a nephrologist in this aspect, something that has been touched upon so nicely by Dr. Matthew Wire.
Thank you, Professor Wonder, and I echo your sentiments on good Guru greetings to each one of you. I think it's a very, very important and a very, very common questions asked. And before that, I would like to share with you my thoughts on treating hypertension in CKD population. And Dr. Wire must be aware of the recent guideline released by KDOGI. KDOGI is a guideline released by the National Kidney Foundation, in which they have specified, and I have to add confusion to the methods of measuring blood pressure. They have specified what is known as standardized office measurement. Now, this standardized office measurement is based on how the person sits, what are the circumstances, is the patient on any other drug or he's taken coffee, tea, and these are the standard precautions which we must take to measure the blood pressure, and they are relying heavily on standardized office blood pressure measurement. And their guidelines clearly predict both for diabetics as well as non-diabetics with proteinuria, mild to moderate or severe proteinuria, except for transplantation of children. The blood pressure targets are less than 130 systolic and less than 80 diastolic. Their evidences are based on, again, the SPRINT trial and many other trials done on that. Now, this was the method of measuring a blood pressure, but they also say that office measurement as well as the home measurement should also be relied upon. So, though there is a confusion, but now we are more clearer. I remember, Dr. Wanda, you've given a talk on techniques of measuring blood pressure, and now we are all more sync with each other on when should the blood pressure be measured and how it should be measured. Second is regarding your question of starting ACE inhibitors and ARBs. I think time and again we've been emphasizing on their very, very important role, not only bringing the blood pressure under control, but also their cardiovascular and retroprotective action. and in addition, a surrogate point of reducing albuminuria. So I would not hesitate to start ACE inhibitors and ARBs. And as very rightly pointed out, that what is required is first 4 weeks of monitoring them for serum creatinine and potassium. We expect the serum creatinine to rise by around 25 to 30%, which is what we are targeting at. And also potassium might go, because of the mechanism of action, there might be mild hyperkalemia. And entirely echoing his sentiments on when hyperkalemia does occur, we need to have other strategies, including reducing your potassium intake of diet and also adding a bit of a diuretic to mitigate the action of hyperkalemia. So I would re-emphasize that stopping ACE inhibitors in ARBs for a milder or moderate degree of hyperkalemia should not be a strategy which will mitigate all the actions of ACE inhibitors in ARBs. So I entirely agree with him. We need to monitor them for 4 weeks, and then subsequently, I would not agree with Dr. Wire of annual, monitoring, because in our setup of patients are a bit different. They may be on so many other medications, including NSAIDs. They may be taking a diet which may cause hyperkalemia, and which they may be on alternative system medicine. I would like to monitor their potassium and creatinine regularly every 3 months. That is my first. This is without any evidence, but this is my personal opinion. Second is on MRAs, and I again entirely agree with you. Now MRAs have emerged with much more stronger evidence, both spironolactone as well as the newer one, Fineron, and the evidence is very, very strong in terms of cardiovascular and renal protection. So yes, if the patient is not responding and is belonging to the group which he described as resistant hypertension, I think the first emerging evidence has been to add mineralocorticoid receptor antagonist. And of course, here you have to be much more careful because the patient will already be on ACE inhibitors and ARBs, and addition of mineralocorticoid receptor antagonist can result in a significant hyperkalemia. On top of that, there's a recent study by Rajiv Agarwal, who's an authority on hypertension CKD. He has given a study of chlorthalidone, addition of chlorthalidone, and has strong evidence to suggest that probably this drug is now a very effective drug in controlling hypertension and also, not progressing with CKD. So my thought is that ACE inhibitors, ARBs, then most of the patients with CKD actually require 2 or more drugs. So we need to add calcium channel blockers. And if not controlled, then maybe a chlorthalidone in the earlier stages of CKD, because later on it may not be able to act. And of course, in dialysis population, we have a different ball game altogether. We need to control the volume status, just to talk to them, to the physician, that yes, you might be encountering a patient with hypertension problem on patients on dialysis. Their major focus is to reduce their volume to make them euvolumic, and then focus on adding antihypertensive. Thank you, Dr.
Thank you, sir. Thank you for sharing your thoughts in such a lucid manner. And Dr. Matthew Wire did mention about the CORD study, and a lot of people did actually were feeling uncomfortable with the CORD data because it was not commensurate with the SPRINT data. But he beautifully clarified actually that when we were looking at only just the blood pressure effect and not having the glucose lowering along with it, which possibly affected the results, were similar to the SPRINT study. Let's hear from Dr. S.K. Sharma actually. How does he manage his patients with diabetes in terms of their hypertension? How effective you are, sir? How aggressive, I would say, you are with the goal. And since we are talking of an individualized kind of a care, diabetics and hypertension actually go hand in hand, and they have multiple metabolic syndromes. So what is your holistic approach in such patients? What is your goal and what is your choice of agents? We are actually now participating in a study by the name of ADOPT study, which is being done across Asia, in which they are looking at more aggressive ACE inhibition and beta blockers in patients with long-standing diabetes. But the results of which are actually, in fact, that study is ongoing. So it is a debatable issue, which is for which actually we are looking at some enlightenment. But what, as an expert endocrinologist, what are your thoughts, sir?
Thank you, sir. As rightly highlighted by you, in diabetics, we are not only dealing with hyperglycemia, but holistic management require looking into blood pressure as well as lipid in these patients. And as our expert speaker highlighted, that even in our patients who are having in this sprint trial, 16% of patients were pre-diabetic, and they were having a problem there.
Please, can you mute yourself, Sanket?
Yeah. So there are 16% patients who are pre-diabetic, and they were getting benefit as seen in most of the sprint patients. Secondly, Chinese study was also having 20% of diabetics, and here again, benefits were there. So in our day-to-day practice, we always look at blood pressure. Every patient has to undergo blood pressure. And in my clinic, we measure twice, because once they are coming in, their usually blood pressure is higher. And after 10 minutes of sitting there, their blood pressure is always slightly better, I should say. But still, 50 to 60% of our diabetic patients are having hypertension as a, you can say, abnormality, and we have to treat them. Another important point is that systolic hypertension is more in these patients as compared to diastolic, and they require multiple drugs. 2 or 3 antihypertensives are required to bring them to the target of less than 140/90, which our ADA says. But looking into recent trials, we see that we should be having blood pressure of 130/80 even in our diabetic patient. Of course, once they have proteinuria or significant proteinuria, we want to have their blood pressure 120/80. So all these things are important in our diabetic patient. And a very important slide which was shown by Dr. Matthew is that once you are having those red bars there and you convert them to diabetic, most of them are having red bars, indicating that diabetes is a condition where more cardiovascular morbidity and mortality is there. And that's why we have to look into that aspect, that they require more tighter control of blood pressure and tighter control of lipid in addition to management of hyperglycemia. Thank you, sir.
Thank you, sir. Absolutely agree with you. In fact, diabetes was called as a CAD equivalent at one time, as you are saying, although there are some issues with that now. But as I hear from the 3 expert panelists and our expert, Dr. Matthew Weir, there are some consensus, I would say, which have emerged. One is that just don't depend upon the office blood pressure. Dr. Sharma emphasized, Dr. NP Singh emphasized, and Dr. Weir actually so beautifully said that automatic office blood pressure or daytime ambulatory blood pressure, or he even said home blood pressure. So when and how, as he showed in his first slide, we measure blood pressure is a very important issue, and we should not actually ignore it, because just by patient rushing into your clinics and you recording a high pressure, that should not be. So that's one important aspect. Second, very important aspect of combination therapy, single pill combination. He mentioned fixed dose combinations, and Dr. NP also mentioned actually that ACE inhibitor with a calcium blocker with a diuretic. A number of these combinations are available in this country, and we often pill burden is an issue. So that's the second consensus, I would say, which is emerging. Third, of course, as Dr. Weir emphasized from the SPRINT study, and also the recent Chinese and other meta-analysis, he showed that greater, more effective control of blood pressure impacts actually. And as he said, as a very astute clinician, as long as it is tolerated well. So patient's tolerance, patient symptomatology is, I think we've had some lovely comments from the experts. I'll now request Dr. Weir to give his impressions before I call upon the 3 experts to give their take-home messages to the audience. We still have 5 or 7 minutes actually that we can. So Dr. Weir, what are your thoughts on, after your talk, some of these discussions that we had as an expert, sir?
Well, as I emphasized, this is not an easy issue. I think one thing I haven't touched on, but we should all discuss, is the opportunity to avoid more complicated treatment later in life by starting earlier in life. And what I mean by that is, if we identify people in their 20s and 30s who have blood pressures in the high 120s, low 130s, who may be overweight, who may already have some glucose intolerance, who may already have a little bit of microalbuminuria, or who have family members with high blood pressure. These are people that may very well benefit from starting on low dose of a single medication earlier in life to prevent progression of blood pressure later in life. Because let's agree, once you have a 55-year-old patient coming into your office with a blood pressure of 150 to 160, more likely than not, they're going to need 2 or probably 3 medications to control their blood pressure. And granted, that can still be accomplished with 1 pill, but sometimes it's hard to get patients to realize the importance at that stage when, in fact, earlier intervention may make it quite a bit more simple. So I think one of the key conversation points should be, how early should we start? And I would submit to you, if you have people who clearly have a blood pressure trajectory from a family with high blood pressure and cardiovascular risk factors, it's probably a lot better to start earlier than wait for blood pressure to be more difficult to treat.
I couldn't agree with you more actually, because we have to pick them early. And as you rightly said, vascular changes will set in once the blood pressure remains uncontrolled for a long period of time. And that's the sooner we actually act in these people. We did actually, I'll share, we recently published our data in the BMJ Open. We 20 years later, actually, we went to the same schools. We had done a school study, and the prevalence of hypertension we found in these adolescents had become double. The prevalence of obesity had doubled, and the prevalence was about to the tune of 6%. In fact, in the urban schools, it was about 10%, and in the rural schools, it was about 4%. So there was significant prevalence in these adolescents. And as Dr. Matthew Weir is saying, we need to pick them up early, and hypertension does occur relatively early, although we say essential hypertension starts between 30 to 50 years, but with more metabolic syndrome being there. I think before we say goodbye, may I request Dr. Uday Jadhav as a cardiologist to give his final take-home message, and also do tell us about coronary artery disease patients, not in heart failure, but patients who are vascularized versus revascularized. What is your thoughts regarding the goal of blood pressure that you like to achieve with them?
The second aspect first as a finishing message, yes. So in patients with coronary artery disease and hypertension, the drop of systolic and diastolic pressure less than 110 systolic maybe and 70 diastolic may have some concerns. The J curve was never been proved without a doubt in the past, but it will be a concern. So probably one may want to keep up the blood pressure by 110 and 70 and above, provided they are not in heart failure. Otherwise, it becomes different. That's one. Second comment is that there is a window of opportunity when we talk about hypertension. So last week at the AHA came this TRIUMPH study from Australia, and they had a interesting thing which we need to continue to implement in practice, is that when a triple combination of drug was used, including a telmisartan, amlodipine, and chlorthalidone, and the doses were half of what we conventionally use, the blood pressure lowering in non-diabetics was 31/50. In diabetics, it was 25/11. And the time at target of blood pressure goal in diabetics was only 44%. Compared to non-diabetics, which was 73%. There is such a big window of opportunity. That tells us two things. Again, coming back to the entire discussion on today, we need to start early and be aggressive. We will have to optimize the doses and then look at this diabetics with 50% not meeting their targets and the non-diabetics 27% not meeting the target. There is a big window of opportunity, and we'll have to continue to implement all the lifestyle modifications along with the appropriate add-on therapy. Thank you.
Thank you, sir, for sharing this latest data with us. Actually, the TRIUMPH study, which has recently been presented, and so beautifully, actually, you have emphasized that diabetics and elderly have more difficult blood pressure to treat than non-diabetics and relatively younger people. So, and triple therapy, as you emphasized. Dr. NP Singh did mention, sorry?
So without undermining the impact of an early treatment for hypertension, the early pharmacological treatment for hypertension, I would re-emphasize the role of early non-pharmacological treatment. That includes, see, all these measures will otherwise, if they persist, the metabolic syndrome, if it persists, will counteract the drug's effect as well. So I think we need to also take this opportunity to re-emphasize or strongly emphasize the role of lifestyle, whether it is salt, whether it is physical activity of at least 150 minutes per week, or whatever ways, including in India. I think yoga has now emerged as, and internationally has emerged as a very, very strong mediator for hypertension control. And we did a study 20 years back, and it's being cited now again and again. So I think, yes, definitely we must emphasize on this, whether it is CKD or otherwise. I think apart from what I said earlier, I think two important things. One is reducing your salt, and when I say salt, it has to be salt in terms of whatever we eat. Otherwise, the compliance on that nutrition will impact your medication management also. And also the emergence of SGLT2 inhibitors for a different cause. Now more it is known as a cardiologist or a nephrologist drug than a diabetologist drug. Now, in fact, DAPA, CKD, and other studies have shown that it not only helps in preventing the progression of chronic disease in advanced CKD as well, but also it can be a very good method to reduce your blood pressure. So I think once the cheaper versions are available in India, more and more patients, whether diabetic or non-diabetic as well, patients should be on with proteinuria or with otherwise CKD, should be on this drug, which has multiplicity of action and is a wonder drug. So your name, Dr. Wonder. So definitely, I feel that yes, we have now different routes of therapies for controlling blood pressure, both in terms of non-diabetic CKD, diabetic CKDs, or metabolic CKDs. Thank you.
Thank you, sir, for emphasizing actually amply as a very senior physician and a nephrologist, the role of non-pharmacological therapy, which has to go hand in hand with the drug therapy. Sometimes we become very drug-centric, but salt-restricted diet, especially more applicable to Indians, because we consume one of the largest amount of salt. Actually, it's been shown in an ICMR study that an average Indian actually consumes 8 to 11 grams of salt every day, which is much higher than actually salt consumed by others. And thank you also, Dr. NP Singh, for mentioning this chlorthalidone study, which I was not aware and I had never practiced before. But Dr. Matthew Weir, actually, even before this study was published in the New England Journal of Medicine last week, he did share with us that such a study is coming out. And so we read this study, and it does show that chlorthalidone can be used in patients with moderate renal failure also, a practice which actually I was taught that patients who have renal failure more than moderate need to be treated with the loop diuretics. But this particular study does show the beneficial effect, and it was shared in the last webinar by Dr. Matthew Weir with us, and something that you have re-emphasized. Last word, Dr. S.K. Sharma. Diabetologists will always get the last word. So since we live in India, and your thoughts as a take-home message for the audience.
Thank you, sir. As in our discussion, it came out that diabetic patients are not only having hyperglycemia, but more risk of cardiovascular disease. And there is 30 to 40% risk of developing diabetic kidney disease, as Dr. Singh highlighted. So our patient has to look into all those aspects. Very tight control. We are developing diabetes 10 to 15 years earlier than the Caucasians. So the early intervention point is again very pertinent to our patients. And then, of course, European Heart Association says that diabetics are not having any low risk. They are either intermediate risk or high risk patients or very high risk patients. So looking into that population, you have to not only go for glycemic control, but very important point is to go for tight blood pressure control and tighter lipid control. So that is very, very important, because the dividend which we get is better when your blood pressure of our diabetic patients is reduced as compared to a very tighter glycemic control. So this is an important aspect, and every diabetic patient should have measurement of their blood pressure, lipid, and of course, we will be intensively treating these patients in these aspects. Thank you.
Thank you, sir. Thank you for bringing the lipid, highlighting that aspect. We normally finish at 8:15. So it is 8:14 today. Over to Dhamdeep for his final comments. And thanks, Sanket and Omkar Swami from the Emcure team. And thanks a lot, Dr. Matthew Wire, for this lovely presentation, Dr. Uday Jadhav, Dr. NP Singh, and Dr. SK Sharma for lovely comments and very enlightening, actually, discussion that we have. Over to Dr. Dhamdeep for the final remarks.
Yeah, I'm delighted, sir, for the vote of thanks and the conclusion. And just to proceed towards the conclusion of this event, virtual event. First of all, I thank Professor Matthew Weir for an insightful talk on today on the topic, the hypertension treatment, specifically focusing on the which goal in which patient. And I think that will definitely benefit the large audience which has witnessed this event today along with us in this evening. Then I would like to thank Professor G.S. Vandasa for the direction throughout this event and directing the specifically the wonderful discussion along with the three experts, the Indian experts, the three experts, Professor Uday Jadhav sir, then Professor Dr. NP Singh sir, and Dr. SK Sharma sir. And definitely all this talk and the discussions will bring out more insights into the minds of all the delegates again who has witnessed this event. Now, with the note, I'm looking forward for meeting all the delegates in the next month with the new exciting topic that will be definitely, as already mentioned by Professor Matthew Weir, that will be the resistant hypertension, targeting the diagnostic and the management aspects of the resistant hypertension on December 17 in the next month. And with that note, meeting in the next month, I would like to say a very good night and good time ahead to all the faculty today and all the audience. Thank you, sir.
Good night, sir. Good night. Good night.
I